Good afternoon. It is so good to see all of you in this space. And I hope you are all staying warm. We're supposed to have very good weather today. So thank you for joining in the respective time and making sure that you all get to your lunch time and anything like that that may be in your agenda is followed. So I'm going to go ahead and get started. Thank you for being in this space and for your interest in joining us to this webinar. This is one of many that we expect to have as well as prepare, and we will have various speakers. So I'm very honored to be with you. We will address today the age-friendly health systems, but I will like to acknowledge two people that made this possible that are here with us, and that is Marcos Garay as well as Maria Llamas, who are the core of our program. This program is brought to you by the Geriatric Workforce Enhancement Program in the Borderland, a grant by HRSA, and I am the principal investigator of this. So age-friendly health system is a framework, and so we will talk about it. So thank you for being in this space. I have no financial interest to disclose. I am just a worker of the university and just enjoying my time here. So we have three main objectives. I know many of you are in all different settings, so I'm trying to simplify it so that we speak more or less the same language as we come together this afternoon. So number one, we would like to learn about the foundations of age-friendly health system, what it's all about, and then identifying the 4Ms framework and within the realm of care for older adults and how that makes a difference in the person's life. And we will discuss how AFHS, which is the Age-Friendly Health System framework, will support the quality of care for older adults, and especially those living with Alzheimer's disease and related dementia. This is important because our grant not only focuses in education and training of the workforce in Alzheimer's disease and related dementia, but also it emphasizes how we as healthcare providers can work together to better the health of older adults. So let's go ahead and get started by doing us a favor. And the favor is not really to get to know you, but also to give you the opportunity to win for a raffle. We're going to have a couple of raffles. So in the chat, please put in your name, if you like, your organization, anything that you can tell us about yourselves. And then Marcos at the other end is already taking notes so that he can put you in for the raffle. So if you would do that in the chat icon is right by your bar where the Zoom is, and it's an icon to have a conversation, and just go ahead and put in that information. And you can do it as I move forward. So the age-friendly concept is not new. It has been around for a long time, and you see the icons or the logos of the various organizations that have been involved in this. The World Health Organization, which has a global network of age-friendly cities and communities throughout the world. And in the United States, has also been ongoing since 2006. However, as has switched to being now a more prominent talk and concept within healthcare. And so that's why it's called age-friendly health systems. So this was initiated because of the need to have some cohesiveness in the care that we provide for older adults. So the concept of age-friendly systems has expanded and now is encompassing or taking care of public health systems and other sectors. So the age-friendly health system that, as I said, it started since 2006, that has now moved into the healthcare arena. You can see here the map of representation of places in our country where they participate, as well as the countries to your right-hand side that are already being recognized as age-friendly health systems. If you move, I'm going to move the icon right here, my browser right here. This map is already old, meaning that it's at least a year and a half old. And when we wrote for this grant, there were absolutely no age-friendly health systems recognized in our area. And since then, UMC, as well as some of the WellMed clinics, have applied and been recognized as age-friendly health systems. And what does that mean? Means that they are already implementing the 4Ms of care that we'll speak of. So what is the movement all about and why are we here? Well, as we know, the factors that are impacting healthcare is the shift in demographics. We have an aging population that it continues to grow, and not only in numbers of the growth, but also the aging process has now been extended, where aging has now been the 85 plus year olds are a group that is already growing very, very much so. And so that creates the complexity, because we know that approximately 80% of older adults have at least one chronic illness, and 1 out of 3 persons have at least 2 conditions, chronic conditions that they must manage, and highly impacts their struggles in their lives. And so it is a disproportionate harm, not only in health, but also how it is influencing our society and the services that we provide, as well as what we have available to support them in throughout the span of aging. And not only are we focusing in the person themselves, but also the support system, which is a majority is the family, friends, and loved ones who are impacted by the aging person. What I'm about to share, this is a slide from 2025, the facts and figures of Alzheimer's disease. And we can see now that when I first started looking at this topic, we were like at 3 million persons impacted by Alzheimer's disease. And now we're at 7 million people that have this condition. So 1 out of 3 persons that have Alzheimer's disease will die. As well as the prevalence of Alzheimer's disease has now surpassed diabetes. And we know that it kills more. When we put all the conditions of cancer, the most common, the breast cancer, prostate cancer, both of them combined are less than what the Alzheimer's disease prevalence is. We also see that who is taking the brunt of the care is caregivers. We see that caregivers are providing there are approximately 12 million people caring for loved ones, and the cost of care that is not compensated has now reached $413 billion. So we can see by these outstanding statistics that there's a lot that can be said about the disease and much work to be done. What's impactful in this, not only the numbers that I spoke of, but we identify that 91% of the people that were surveyed regarding wanting to know what their cognitive status is, and if they were to have Alzheimer's disease or be diagnosed, 91% identified that they would like to know. Whereas before we used to, when we polled people, the numbers were much less. So because of the changes in treatment and the scientific advances, we now have more awareness of the disease, as well as treatments that may be initiated early on. So here is the age-friendly health system mission, and that is to build, it's a movement to build care that is comprehensive, individualized, and according to the services that are available. Keeping in mind that it is the delivery of equitable care. Equitable means that all older adults will have the opportunity to be evaluated within the framework of the 4Ms. The idea is that we have not only evidence-based actions, but also the idea that we will limit the harm that a person may be undergo, and that we consistently be aware of what the person's wishes and the family or loved ones have in regarding to the health or functionality of the person. So, what is all the fuss about healthy, friendly systems? Well, it's a growing momentum in that now healthcare settings are recognizing that it is a value. And so, a number that we saw maybe 2 years ago, before when I joined the web, was that there were approximately 3,000 sites with age-friendly health system recognition. Whereas now the momentum has gained, and now we have approximately 5,200 sites in the country. And as I mentioned, our city is not any different. And then we call it a sticky frame. Why? Because it resonates across disciplines. It is not just for direct care workers, but it could be for social workers. It could be for physical therapies. In other words, the interdisciplinary team that cares for the person would be greatly impacted in the ability to use this and implement it in all cities. So it simplifies how we are approaching care. And then we have the opportunity of learning together and not judging each other, but rather following this framework that guides us across the continuum of care. So learning from the movement is informing also the regulatory agencies and creation of policies, because now we will begin to speak in the same type of language. So many health systems have found it that they have already aligned within the 4Ms and gives the opportunity of providing evidence-based care. And in addition to that, I like you to recognize that Center for Medicare and Medicaid, as of 2024, started looking at the 4Ms of care, and also in the hospital setting, which is acute care setting. And now it is being evaluated as one of the qualitative measures that is connected with financial reimbursement. So how do these 4Ms work together? Well, as you can see in the bubbles, we have, I'm sorry, I moved a bit fast there. So we have medications as the number one. And why I chose medication as the first thing to evaluate, you will learn in a little bit. We also have mobility, mentation, which has three components within that. And the most important one is what matters. Medication is something that is a concrete evaluation. We often see it when we evaluate patients. Is one of the main things that we look at. What is the patient taking, whether it's prescription or non-prescription? So it is important and imperative that we review the patient's medications, no matter who we are in the healthcare setting. Even if physical therapists, we need to know, because there are interactions that can potentially cause harm, or there are medications the patient may be taking over the counter, such as alternative therapies, that can be interactive and harmful. We want to always evaluate whether these medications are beneficial, as well as making sure that it's not impacting the cognitive or the psychological aspect, as well as the mobility. So it's an interactive component that crosses in all the M's. So I know that it is a burden for many of us, especially those in healthcare, to be reviewing medication, but it's something that we need to understand, because the variation that can occur from the classification, such as benzodiazepines, opioids, or even highly anticholinergic medications such as diphenhydramine, which is a trade name is Benadryl, are highly impactful in the cognitive and mobility aspect of the person. So we have to account for all medications, whether they are prescribed or non-prescribed. Along with that, you heard me speak of evidence-based practice. Well, the tools that we use to evaluate, and it is ideal that we select those that are applicable to our setting, is how do we evaluate whether the medications that the patient is taking are appropriate or potentially harmful. So there are several tools. We have the Beers criteria for potentially adverse medications, and that is evidence-based, list the medications that classify how the medications may interfere in some of the other M's. And then additionally, they have come up now is the American Geriatric Society. They, along with the Geriatric Society of America, have come together and brought out a paper on what are the options for the medications in case a person has to take that specific classification. We also have the Stop Start, which is screening tool of older persons' prescriptions. And the START is a tool to alert whether it is the right treatment. So these have explicit criteria. And the whole idea is that we should evaluate medications for consideration of deprescribing. It is not unusual, as I mentioned, that a person has 2 or more conditions, and therefore it is highly likely that a person will have 5 or more medications, and that is considered polypharmacy. So the goal is to reduce the harm while supporting the physical function as well as the cognitive function of the person. And although some of you may be promotoras de salud or maybe work in hospice or in other settings, and you may think that medications is not as applicable, in reality, it is important for all of us because medications impact the person's functionality and ability to make decisions and to care for themselves. The second M is mobility. As you can see this lady dancing, that's how I would like to continue my life as I continue to be grayer and age, I hope, gracefully. But mobility is super important because if you don't move, so mobility, I see it as something that lubricates your joints on a continuous basis. And I say en español, ungüento es movimiento, el movimiento y el ungüento vienen mano a mano. So mobility is something that we can do and encourage our loved ones to do. Why is that so? Because we know that mobility not only improves the musculoskeletal system, but it also improves the alertness as well as that social interaction that the person can have with others. So it is appropriate to get them moving, even if they are wheelchair bound. There is some programs such as Tai Chi in wheelchair, yoga in wheelchair. There are a multitude of things. And those of you in the physical therapy department or occupational therapy are more adept in identifying ways to keep them moving. But the whole idea is that the person must get moving. All this helps us to understand that we have to evaluate the person's abilities, not only physically, but cognitively, as well as what is safe for the person and what is acceptable in their culture. So as I know I can speak for myself that dancing is something that is appealing. However, if it's a person that dancing was never part of that, may not be something that they want to do. So we gotta create a way to find a safe way to keep it on the go, moving, and evaluating the potential for fall risk. We know the falls is among the top conditions of high mortality among the older adults. Fractures, hip fractures, we know that also that when a person sustains a hip fracture, the quality of care of life decreases and mortality occurs within a 5-year period. So we definitely want to avoid that. So if we want to jointly with the person, the family, create a prevention plan to avoid some of those safety concerns that we have. I'm going to pause right here so that I can catch my breath, but more importantly, to remind you that if you have any questions, go ahead and write them in the chat. And Marcos and Maria are monitoring this area so that they can alert me and we can talk about it further. So not only do we evaluate the person for mobility as a direct observation, but we have to think about possible evaluation tools that we can use in our setting. And why is this important? Because there is always an opportunity for improving as well as to giving an objectivity to our examination that can be documented and can be credited for recognition and action in one of the 4Ms. So a couple of tools that you will see here is the timed up and go. And the time up and go test is something that can be done in a setting. All we need is approximately 12 feet of space, and we observe the speed at which the person walks. The other one is stopping elderly accidents, death, and injuries. Study is a set of screening questions. It takes approximately 30 seconds to do strength testing, gait assessment, and even just screening questions. So long as they are evidence-based, you cannot go wrong. If you have other ways, like subjective ways, asking the person, have they fallen in the last 12 months? If they have, it's important to know whether they have fallen indoors or outdoors. We know that by the literature that when persons sustain injuries within the home, it more than likely is because they are more confined in the home, they spend more time there, or they may also have more frail state since they are falling in a environment that they know. So it is information that will help you create that plan of care. The next M, the third M that we'll speak about is mentation. And mentation is a broader M. Not only does it go with the cognition, but also encompasses the mood. So within those, we identify dementia, depression, and delirium. Those are the three main Ds. They are evaluated differently, they present differently, but we may be seeing them across all care settings, across all disciplines, and across the continuum of care from 45-year-olds and above. So this is the reason why we have to be aware that and know what each one of them is. And as the slide points, dementia is not diagnosed in the inpatient setting. In other words, just dementia does not just all of a sudden appear. When suddenly a change in cognition appears, we're speaking more of delirium, which is a rapid event. So here is the very well known, maybe to some of you may not be, but the dementia umbrella. When we speak of dementia, we're not always speaking of Alzheimer's disease. Dementia is the broad term. It's the umbrella that encompasses that loss of memory, the ability to think, or ability to work through the challenges of life on a daily basis. So maybe difficulties with activity of daily living when before they were fine, or we may see subtle things that we will speak of. So the types of dementia within it is Alzheimer's, which is the largest percentage, approximately 80% of dementia comes within the Alzheimer's. There's also vascular dementia that we often see when we have persons with chronic conditions, especially like diabetes, hypertension, atherosclerotic disease-related conditions. And then we have Lewy body. Lewy body, we have that where you presents more of a psychological condition that is a pathological presentation. And if you remember, Robert Williams, the comedian, he had Lewy body disease. And so when he was diagnosed, it is thought that he committed suicide. They do not know whether it was because of the condition or it was depression related to the condition. And then frontotemporal presents more of verbal difficulties, abilities to retain information and to speak it. And so the Bruce Willis is a famous actor that has been diagnosed with frontotemporal dementia. And then we have others such as Huntington's chorea, which is a genetic condition that presents very early in life, but it can be well traced along the lineage in the family. And then we have mixed dementia, which we believe that is a good number of cases where we have seen any of these conditions along with Alzheimer's disease. And I can speak about a loved one in my family who had mixed dementia, but initially was vascular and then later on was diagnosed within the Alzheimer's realm. And the longevity is different as well as the presentation of disease, with a commonality of loss of cognition and thinking abilities. Let's move on to depression. Depression is something that unfortunately does occur at a rather impressive prevalence. And unfortunately, Texas ranks 8th for seniors with depression in the country. And so what we have here is a problem that has continued to escalate. And recently, I was in an in-service from SAMHSA and found that now the 42% of the suicide rates are occurring in older adults, with older adult men being most impacted, with lethal weapons or lethal ways being the manifestation or the event of death. So it is something that we have to have in the forefront as we look at cognitive decline or maybe physical decline. And unfortunately, 80% persons who have depression can have a treatable condition. So us as providers, as advocates of our aging population, we must talk about the prevalence of depression as well as the importance for early recognition and early evaluation and treatment. Delirium, on the other hand, often is thought of as sundowners. And those of us who have worked in the hospital or have loved ones may see that when the evening comes, our loved ones with either chronic conditions or Alzheimer's disease or other conditions begin to hallucinate, perhaps, or become different people than what they were during the daytime. So a screening for delirium is critical. Where do we see delirium? Well, we see it all of a sudden when something happens, such as we see it in the summer months or when a person is ill. Why? Because they may be dehydrated. Older adults may not have an overt hyperthermia or what we call as fever, and therefore we do not have fever as the top sign in older adults. So change in their cognition or in the way their behavior, the way they're communicating that occurs suddenly, we have to think of delirium. And as you see here in this image, this is how delirium may present. They may be very active and all of a sudden they just are slumped and they don't want to do anything. They have pain, but they don't know how to express it rather than a change in behavior. They might all of a sudden not be able to concentrate, may have a sudden change in their behavior, such as they were calm people and all of a sudden they are very anxious. In extreme cases, there's hallucination, agitation, confusion, and this is where the patients may become combative. So the key for the recognition of delirium is that it is an event that happens within 12 to 24 hours when something is not right in their bodies. And so we want to look always as to what has the person taken. Perhaps they mixed their medications, or maybe they didn't take their medications, or they have something else, pain that has not been recognized. If a person that has dementia, especially those in advanced stage, may not be able to express pain, and therefore delirium may be the ways that they are exhibiting that behavior. So it is something that is often seen at all settings. We seem to be more cognizant of its occurrence in doing hospitalizations, but I, as a clinician, receive calls from patients whose loved ones all of a sudden have had changes in behavior. And here are some of the mentation evaluation tools that you can use for depression. The PHQ-9, the GDS, in the hospitals, PHQ-2. And for deliriums is the CAM, the Cognitive Acute Memory test, and then the mini cog is something that we use very widely for dementia in primary care settings where they have to write, draw a clock and identify or enter a specific time. And then the MOCA test is the Montreal Cognitive Assessment, and that is used more in a greater depth of evaluation when cognition has been identified to be a problem. So these are common tools that you can access, and we will give you some resources at the end. Let's move on to one of the areas that is often overlooked, and that is what matters. And you're like, what? What matters to whom? Well, this is a way, in one of the M's that we identify, is a way to render evaluation and treatment that is according to the person, meaning it is we center on what the person wants, who they are, what their loved ones are. So we need to know and plan our care according to what are their goals, what are their preferences. And the question that we often ask, at least in primary care settings and even acute care settings, is we ask about advance directives. Why? Because it's a check mark. It's something that we have to do and we have been doing for a long time. But we are moving not beyond that. And that is to begin to look at what brings value to the person. And so that allows us to plan the care accordingly to what's important, such as, is hygiene important to them? And most people would say, no, they don't want to bathe. Well, if they don't want to bathe, if a person with Alzheimer's disease, especially that is at an advanced stage, may not want to bathe, well, we have to look at what are maybe the reasons. And we have to be like inspectors evaluating. What is the environment? Perhaps it's too cold. Older adults are sensitive to temperatures. Perhaps they're in pain and they don't want to move. And we have to remember that not everybody has to have a bath every day or every other day, but working that out according to what the person's preferences may have been when they were able to make decision, or what the family desires for them. We also have to look at faith. Faith is not the same as religion. And what's their spirituality belief? What should we be aware of that brings comfort to them? And always keeping in mind that we have to give the patients an opportunity, or person, our loved ones, an opportunity to share their fears and concerns about their health, perhaps even talking about what they fear the most towards the end of their life. What are their desires? What are their concerns as he deals with health or anything that matters? Here are some possible questions that you may consider in asking about the family. Who's important to them? Who they would like to remain in touch with? What is it that they want to do to maintain mobility? Why is mobility important? What activities may be of value to them? And when they get medical care, what's important to them? For as an example, that they can afford it, that is comfortable, they can make decisions. You can come up with many things, but the whole idea is that you begin to focus in the person. So we reviewed the 4 M's: medication, mobility, mood, and what matters. We're now moving to talking about the age-friendly health system as a whole. Why are we wanting to use it, and why? How can we qualify for it? Well, why do we want to use it? And this is based on research. We know that improves patients' experiences because now we're looking at them as a person. It will cost less if we don't, if we can prevent some of the falls, early recognition, perhaps of the cognitive decline or the mood disorders, identifying medications that may be harmful to them, and better outcomes in a sense that we have that early intervention. And the clinician's well-being, the fact that we can objectively see that we're doing the best that we can, and collectively being able to gather that information. And overall, which I had already alluded, the health equity, meaning that all patients, independent of who they are being evaluated in the same manner. Now, evaluation in the same manner does not mean that we ignore who the person is and what their preferences are. When you look at the business aspect of why we want to become age-friendly health systems recognized, is because we know that if we focus in those 4 M's, early intervention, early recognition of what may be going on, and making changes accordingly, then we would go ahead and prevent perhaps unwanted hospitalizations, recognizes that the condition when is beyond being able to be taken care of as an outpatient or in the home setting or wherever they are, being able to maintain that mobility by lessening the injurious falls, taking care of their skin, identifying pressure source or any pressure points, and avoidance of venous thrombosis if we keep moving them when as it deals with the M of mobility. And then mentation, that early recognition and identification with knowledge of being able to differentiate between among the 3 Ds, with delirium being connected to possibly an acute condition that may be going on, then we can prevent perhaps a hospitalization, and in depression, maintain functionality as well as that prevention of what I spoke of increasing mortality. So dementia in itself, and knowing what dementia is, recognizing the 10 most common signs of dementia, which is the loss of memory, changes in their behavior, ability to lose mobility, or even ability to socialize with others. And we must remember that anything that we do is not a cookie cutter. One size does not fit all. There are different age-friendly care settings, and therefore the 4 M's may look different of how they are evaluated. As an example, we have settings in the hospital. The hospital setting is acute care. So we still deal with the M's, but with the tools that we may implement in the plan of care may be different as opposed to in a nursing home or a long-term care facility where it's actually the patient's home and they are there for longer periods of time and perhaps in a more frail state. So early recognition and getting to know the patient or the person as a person, not only what they are at now, but what they were before, to incorporate that personal care. Then we speak about ambulatory care, which is where many of us may be working, and that is in the outpatient setting. How do we maintain that patient mobile to be able to come to our services or to be able to support him to remain in their home? Convenient care clinics, this is like urgent care sites. Home health, definitely home health is one of the sites that age-friendly care settings care can be implemented. There's already been hospitals that have achieved geriatric surgery verification, such as programs that were initiated by the University of Utah, and sites that have achieved geriatric emergency accreditation. And I know that UMC is emergency department has already sought this out. So as you can see, not everything is the same, but we fall under the same umbrella of age-friendly healthcare systems that can be implemented. So there are 2 levels of age-friendly care. These are the 2 levels that we are identifying. Of these, what are those care levels? Level 1 and level 2. And what can we do to achieve the first level, which is to get us started? Well, recognition comes from the Institute of Healthcare, the Institution of Healthcare. And so is hospitals, practices, and post-acute communities can achieve the 2 levels. And so as I had mentioned previously, up to date, 5,200 settings have been involved. So the age-friendly health system, there are 2 levels, as you can see here. The participant, as well as those who are committed to care excellence. That means that they have moved from level 1 to level 2. And so level 1 is when you begin to recognize how you're going to put those 4M together into the practice and being able to recognize you're likely already doing something in your settings. So looking back and saying, what am I doing? Even if you are a faculty member, what am I teaching related to geriatrics that encompasses these 4 settings? And perhaps if you're working with a community agency, a not-for-profit organization that renders volunteer care, this may apply. So it can apply to any practice that implements the 4M. So the 4M at level 1 is where you gain that interest to initiate it. This is just a redundant slide to what I already spoke of, what the sites that have achieved care site recognition. So level 1 is identified as a participant, where a team develops a plan to implement the 4Ms. A team, it could be any professional or non-professional. It could be caregivers coming to your help to aid in how do we get there. And then completing the 4Ms description worksheet, which is now online. And we are currently working with 3 practices getting ready to pilot test the 4Ms implementation. And the process is fairly simple. It's that we can put it in, we can evaluate and start that to be a participant in 3 to 6 weeks. All that is sent in to the age-friendly healthcare system, where they evaluate to see if we have the support that will allow us to move to level 2. So level 2 means that we are committed to sticking with 4Ms, meaning those that we're going to provide care incorporating these components. And that's first, we have to be level 1, and then we measure data and people that receive the care within the 4Ms through either direct observation, a chart review, or even evaluating the electronic health record where the information is stored. So the chart review can be manual in paper, or it can be through electronic health record. And then we monitor for 3 months, and then we submit for verification. So putting it all together, what the 4Ms is doing, this 4Ms framework, is something that allows the care setting to have some commonality. And so we have to reflect, what is our setting doing? Which one of the 4Ms are we doing, and which ones can we do better? And how can we incorporate that in our practice? And if you are not a healthcare provider, is your loved one, or are you getting care that is within that framework of the M's? So you're doing, what do you need for your team to be successful? What do you need to be supported to implement something like what we talked about? So here is our pitch to help you. The Geriatric Workforce Enhancement Program here at UTEP is supporting you, meaning all the agencies in our region, to achieve level 1 and level 2 if the recognition, if it's desired. All you have to do is contact us. We have learned and practiced how to get you there. Why? Because not only would you excel and stand out among your peers, but you will also show your commitment to rendering quality of care for the older adults that you serve. So what do we do for you? We help you achieve recognition levels. We give you in-service on the 4Ms. We help you evaluate what your gaps are. Perhaps we help the leadership team to support you. And then we help you implement the target interventions in each of the 4Ms. And happy to tell you that this year we do have some funding to help agencies that are willing to go through this to help you offset some of the cost of being able to implement the age-friendly health system. And then we will also assist you with monitoring results so that you can have a quality improvement plan that you can share with your business partners and even your clients about how to improve your services and how you are achieving those programs. So here is a website where you can access free educational resources. We do have resources that are bilingual. please take note of this email. You can also, in there is a request that you can make of what your needs are, as well as our emails, so that we can stay in touch with you. And with that, I will end by opening it up to questions or comments. Thank you. Are there any questions that you would like me to address or any comments? Are you guys still awake?
Yes, I'm awake, and thank you so very much for this information. It's very informative.
Thank you, Monica. Anyone else? I see tons of my colleagues here, and colleagues from practice, colleagues from the community, as well as faculty. So any comments would be greatly appreciated before we go into the raffle.
Thank you very much. It was very informative, particularly the information about the 4Ms, at least for me.
Great. Thank you, Dr. Lara. So here's a slide where the website is. Marcos, can we move? He's going to put in the chat, and I wonder if we can go right into, I'm going to share with you. Can you all see? No, I'm going to stop sharing. And let's see. Can we show him the website? Can we share him the website?
Abre su Firefox o en esta pantalla.
Oh, it's sorry.
Por allá. Está al revés. Por allá. Hacia todo el lado izquierdo. Su mouse. Todo hasta el lado izquierdo hasta que aparezca acá.
Oh, I see.
Solis, I have a question.
Yes.
As far as the slide presentation that you presented, would that be something that would be able to be provided?
Yeah, if we can provide the slides, right, Marcos? Yes, definitely. You can just put it in the chat,
Okay.
and we will be more than happy to share that with you. What you're seeing right now is a website.
Okay.
And so here's your website. And so here you can see you have a description of who we are. As I said, we are a geriatric work enhancement program funded by HRSA. We have our grant yearly, and this is our second year. So it tells you a little bit who we are, what we do, as well as opportunities that you can go. If you go here and this, you will see the various things that we have. It's right here. It tells you the services that we can provide. You can request anything that you would need. Education, we have educational programs for professionals and non-professionals, as well as caregivers. And I would like to point out to you that February, and invite you, we're having an in-person seminar at the Sunlight Conference Center on February 6th, and it's a half day. There will be NCDPs, which used to be CEUs for nurses and social workers. We have plenty of room. We have 150 seats available. It's open to all disciplines. Anyone interested in what we're going to do is we're going to bring experts in the field of Alzheimer's disease and bring it into the framework of age-friendly health systems across the continuum. And so we have 3 geriatricians and a nurse researcher that will be presenting at the conference. It's 8 to 12:30, February 6th. So I hope you can join us, even if it's for a couple of hours, and come and learn about what's going on in the world of Alzheimer's disease and related dementia. So you can see here we have student programs. We're very active with our students. And then here in resources, we have educational resources. We have a dementia booklet in English and Spanish that is really, really nice. It was designed by our students and it's available. You can download it. We do have some hard copies that we can make available to you. So you just need to request it. I'm going to go back and here's the one in Espanol. And everything that we have, we try to have it in both languages. We're trying to reach as many of our community members as possible, and we are expanding to the rural areas. Are there any other questions?
I'm sorry, I have a question. You said,
Yes.
how would you be able to get that book that you mentioned that was
If you go to the website that I share with you, and
okay?
it's in the chat, you can go here. We shared it. I went
Mhm.
all the way back here, and then you can go to resources. Can you see
Okay.
my
Yes, ma'am.
browser? You
Yes,
can
ma'am.
go to resources, and you can scroll down or go down, and here are the booklets that I pointed out to.
Okay, thank you so
Mhm.
much.
And then anything that you want, any services that you want to request, you can just scan this. And we have lots of educational resources. We have online continuing education that you can get credit for if you're a nurse. And they are from the NYU, New York University, the Hartford Institute of Geriatrics. We have partnered with them, as well as modules that nursing assistants can complete. Everything that we offer is totally no cost whatsoever. So please take advantage of that. These are your taxpayer monies at work. And we're very happy to share anything that we have. We are also open to any invitation that you would like to extend to us to speak to your groups, or now that we are going to send you the slides, you can even share that with your agencies.
Now, question on the CEUs, and those are for nurses, since I'm a licensed vocational nurse, those are accepted by the board?
Yes, they have been approved by UTEP's continuing education,
Okay, thank you.
and it's for 4 hours.
Great, thank you.
Anything else, guys?
This is Sarah Ivonne Jimenez. Can you hear me?
Yes. Hi, Dr. Jimenez. Good to have you in this space.
Yes, thank you so much. This was such an excellent presentation. I learned so much about the 4Ms today. I really hadn't known as much about it before, so thank you so much for that. I was just wondering if our hospital organizations like HCA, UMC, the Hospitals of Providence, are they embracing also this model in their education departments? Do you know?
Excellent question. We're very happy to tell you that we have a partner from day one with a UMC primary care services. We are also engaging with the emergency department. So we have not directly done in services with professionals in the hospital. However, we're about to be presenting to the employees. Coming up in February, we will be having an in-service for them. So yes, we are embracing that, and the geriatricians that will be with us for the February 6th are actually physicians within the UMC system.
Great, thank you so much.
And of course, you are a featured speaker as well.
Oh my goodness, yes. Thank you, Dr.
Thank you.
Solis.
Thank you for your partnership.
Thank you.
Anybody else? I'm going to stop
I
sharing
have
here.
a question. For that
Yeah.
seminar that you mentioned on February the 6th, is there a fee for that?
No, totally free.
Oh, great.
Uh-huh.
And you could
Anything.
be able to register as well, going through the website?
Yes. And Marcos, can you put the link where they can register for the Eventbrite for February 6th? He's going to put, Marcos is going to post the link where you can register for through Eventbrite for that February 6th. We, as of right now, I believe we have 60 people that have registered, and we have capacity for 150. Thank you for being such great audience and for just caring for our communities, and more than anything, take care of yourselves. Thank you, guys. I'm here if you have questions.